Good. Good afternoon, everybody, and welcome to our governing body meeting. Really good to see you all as always. We'll just quickly go through the protocol for the video meetings, although these should be etched in our hearts by now. So just a couple of things. When you first speak, if you could just kindly introduce yourself, and secondly, just a thing about acronyms, if we can avoid them. Well, then that let's make a start. We start on a sad note, really, because today marks the end of the roles for a number of GP colleagues and also some clinical directors at the governing body. And I just wanted to take this opportunity to really say a huge thank you for the contribution that you've all made, those who are on the call and those who are not. It's been an incredible 10 years or so with many of you, and I've really appreciated the advice, challenge and support. And I know throughout the period we worked together, what has always been at centre stage is the people of Oldham. So every conversation we've had, every decision we've made, no matter how difficult it's been, no matter how many disagreements we've had, no matter how many sort of differences of opinions we've had, where we've settled is what is in the best interest of the people of Oldham. And for that, on behalf of the people of Oldham also, I think we owe you all a huge thank you, and I want to sort of say that to you all personally. And I know many of you are still in Oldham and you're going to carry on working in Oldham, and I'm really sort of looking forward to carrying on working with you and seeing the benefit to the people of Oldham, and many of you we will still benefit from your advice and guidance. Second thing I wanted to say is a huge well done to Dr. John Patterson, who this has probably come about because of the recognition of the amazing work that he has been doing in Oldham. He's taken up an honorary role advising the Secretary of State around primary care, and much learning I know John is going to take from Oldham into that role. But more importantly, we'll be really confident and hopeful that that is going to deliver enormous benefit for the people of Oldham and the rest of the country. Indeed, a much deserved role, John. And again, I want to thank you personally for everything that you've done for Oldham and continue to do for Oldham, and wish you well in that role. And those colleagues who are leaving, wish them well with everything that they're doing. So thanks for that, and then we will no doubt hear from other colleagues about colleagues too shortly. So I'll move on then to the next item, which is apologies for absence. Have you had any apologies?
We've had Dr. Gopet, Dr. Nazgil and Katrina Stevens.
Yeah, and Shelley, she's had to leave for another meeting also, so she was with us a short while ago. Okay, let's move on then to declarations of interest. So any new declarations or changes to the published register? No, any declarations with any of the agenda items? No, as we get into a conversation, as usual, if anybody feels that we're straying into any conflicts, please do make me aware of them. Okay, we move on then to item 4, which is proposed changes to the quoracy in light of the leavers and stuff. So, Erin.
Chair, I'm Erin Portsmouth, Director of Corporate Affairs for the CCG. So as some background, we were expecting originally that Oldham CCG would disband at the end of March. Nationally, all CCGs effectively have an extended close down period, so we will be operating within the first quarter of the next financial year between 1st of April and the 30th of June. So for that reason, we did decide at a previous governing body meeting to amend the governing body membership to focus on the statutory membership for those that period of those 3 months. But because of that, we also do need to adapt the quoracy. So what you'll see on page 4 is a suggested quoracy of 3 core voting members to include at least 1 lay member, at least the accountable officer or the chief finance officer, and at least the chief clinical officer or the executive nurse or the secondary care doctor. So what you've got there is at least a lay member, at least a clinician, and at least another officer. So yeah, so this is brought to the governing body for approval. It would come into effect from the 1st of April.
Okay, thank you very much for that, Erin, and makes sense. It's a sensible approach. Any colleagues got any comments or questions? No, if not, I'd be happy to approve the proposal. That's brilliant. Thank you very much for that. So let's move on to item 5 then, which is the minutes of the last meeting. Seems like a lifetime ago, 23rd of September. I'd be happy to approve those minutes. It's an accurate record. Good. Okay, let's move on then to the action log. So a couple of things there, Nicola. With patients, contact with John and Eve's parents. Any updates on that one?
So Nicola Hepburn, Director of Commissioning Operations. I understood that this had been closed at the last governing body. We've been to coroners, we've had conversations with them and their active members on patient and advisory groups, and that had been an agreement made. Eve's parents are still very active across Oldham and are included, and they feed into other consultations. So I think the action is firmly closed.
Okay, thanks for that, Nicola. And the subsequent 2 are complete, and the emergency planning is on the agenda. Okay, so let's move on to item 6, which is Mike Barker, Accountable Officer update.
Okay, thank you, Majid. I want to introduce myself. You've just done it. Couple of things I want to say as part of this paper in addition to it. So Erin's just confirmed that the CCGs will extend until the 30th of June 2022. As of today, I had my second letter from Amanda Pritchard confirming my extension, and we've already extended Kate as our CFO for that period of time as well. So that's now all sorted out. Greater Manchester's appointed a new chief executive, Mark Fisher. Great appointment. I'm not going to say any more than what's in the paper, but that I think will bring some new level of stability. He will remain in designate appointment status until the 1st of July, but he will be working in GM between now and then on a more flexible basis as he transitions from his existing role in the Cabinet Office into his new role in Oldham. I'm sure we'll all welcome him when we get the opportunity to meet with him over this coming period of time. You'll recall that the integrated care system has 2 formal parts to it: an integrated care board and an integrated care partnership. I think I've already confirmed that Sir Richard Leese has been appointed as the chair of the integrated care board. He's appointed 2 non-executive directors, now obviously a chief executive. I believe a medical director has been interviewed, and I'm not in a position at this point to say if one has been appointed, but I hope there was a successful outcome. The finance director interviews are tomorrow, I believe, and the nurse director interviews will take place around Easter time in a couple of weeks. GM's also confirmed the appointment of a chief people officer in Janet Wilkinson, so that's in the paper and noted. And we're now coming out of phase 2 consultation, which incorporates the place-based lead roles for health and care integration in places. Of course, Oldham's one of the 10 places of GM. I'm not going to say too much about that, other than the consultation's complete. There was a significant amount of comments and responses received, and I understand that there is a time frame now which takes up the next 6 to 8 weeks before an outcome of those 10 appointments will be made across Greater Manchester. In terms of finances, we will cease to exist on the 30th of June. There will be a running cost required to fund the GM infrastructure and the place infrastructure. A lot of work has done and progressed. I still think there needs to be formal agreement between the GM and place leadership budgets. I think we've seen some indicative values that Kate and I are working through, and there needs to be confirmation of what the permanent structures are going to look like. I mean, I firmly believe that it'll be a lift and shift on day one, and there'll be organisational change processes on the other side of day one, being the 1st of July, for a period of time afterwards while we settle down the new structures. On the 1st of April this year, we will formally start the TUPE consultation process for all staff impacted by change at sub-board level or sub-governing body level. For the avoidance of doubt, that's the majority of people in Greater Manchester across the 12 employing organisations that currently exist, which is the 10 CCGs plus GMSS and Health and Social Care Partnership. In terms of the rest of the paper, what I've tried to do, as we've moved into a new organisational format ahead of the changes and put in place the shadow arrangements, we've been working increasingly through the system board to get the new arrangements put in place. And if you recall, the governance that we set up was to provide this governing body with assurance of what was happening. By way of a summary, I've included the items that have been considered over the last 2 meetings. We have, of course, met 6 times roughly now in shadow format, because we were quite well advanced in our planning and setup. So, I think we're making pretty good progress around the execution of organisational development. As a proposal came forward in February, and Julia Veal and the HR and OD team are taking forward the implications of that. I'm sure there'll be updates as we go through the next couple of months. We've made good strides on agreeing and confirming the scope of integration, so we've got one whole system approach to all of that. Kate's been very instrumental in setting out some policy position papers around finances and pool budgets and locality-based budgets. We've now got the detailed work to do to finish off over the next couple of weeks to bring them into life. And then earlier this year, we considered some pretty important things around our main acute provider, the Northern Care Alliance, and HIT's direction of travel and how that fits in with our proposed development in Oldham. The most substantive one is the service development strategy that they've laid out. Just to confirm that myself and colleagues across Salford, Rochdale and Bury are now working together to understand what are the things that we could do across those 4 footprints together, once and once only, or in a mutual way that benefits our citizens and residents, whilst not encouraging the hospital to do it 4 times. And that work will evolve over the next period of time. I don't think it'll be a quick piece of work. And then finally, I welcome to Saeed Osman, who takes up the new role as Deputy Chief Executive in the local authority. And some colleagues on this call will have already met Saeed. Indeed, someone was in another meeting with him this morning. Of course, it was System Board this morning. And Anthony Hassel will take up new post of Chief Officer or Chief Executive for PCFT, alongside Gaynor Mullins, who will be the new Strategy Director and will be the main strategic organisational link for Oldham. And then since we last met, 2 papers at the very least have been published nationally. I've tried not to kind of overwhelm you with all the policy documents coming out from the centre. One is 384 pages long, which is Levelling Up white paper. Pretty decent read, actually, if I'm being honest. It talks about the government's desire to move to a mission-based framework, and it sets out 12 missions. The one thing I'd take from that document, if you've got time to read it and desire to read it, it's one of the first policy papers I've read in a very long time that actually encourages health to be in everything, not as a standalone thing. Now, I can understand an argument of some people saying, well, it doesn't give it as much importance, but I'd strongly encourage us to recognise this is about health becoming more important and linking it to every single thing that takes place in society. And we all know the benefit of that. So I think it's good on that basis, but there are particular aspects of the Levelling Up white paper that have more of an emphasis on health than you perhaps might give it credit for. So it's worth a read. There's summary versions all over the internet if you're so inclined to read it. And then the other one is probably a more seminal paper called Joining Up Care for People, Place and Populations. I'm pretty delighted to be associated with at least one of the authors who used to be our accountable officer, and has had a hand in some of the pages in that document. I'm sure we'll all recognise some of it because a lot of it talks to our model, funnily enough. But I've seen quite a lot of hoo-ha around the place saying we've got a health and social care bill and now we've got another white paper and another white paper. I'd strongly encourage us to be in a place of thinking that this actually provides another piece of the jigsaw. There's nothing too much in there that we would disagree with. It sort of really sits and fits with our model of care, and indeed the kind of things that we are pushing for. So, the concept of a single person accountable for health and care integration, a shared and single budget with joint accountability in places focused on communities, delivery of services wrapped around populations of 30 to 50,000, all the good stuff that we think is important because of the evidence around that is in that read. And it's a very slim read at 20 odd pages long. It's not a heavy paper to read. So there are implications of it though which will become very clear over this next period of time. So one of the commitments in that paper is a review of the current Section 75 framework, and of course Section 75 being that of the 2006 NHS Act that encourages and enables us to pool funds. The current makeup of that legislation is quite complex and quite challenging as we move into this next phase of integrated ways of working, and that paper kind of makes a commitment that the government will review the Section 75 legislation, it will change it, and it will be more permissive, I think, at that point, till we get to a place of really understanding that we don't have to just pool between councils and NHS. We can start to include, hopefully, things like primary care, particularly around the PCN network stuff, which is proving quite challenging for us legally. We've got a very high desire to do that, but we're kind of struggling with the legal mechanism by which we would do that. For me, it's an important message there because our model starts with primary care being right at the heart of what we're trying to achieve, and communities being intrinsic to all of that. And I could describe that many different ways, but that will do for now. So I'm more than happy to take questions, Maggie, but that's my update report this month. Thank you.
Thank you very much for that really comprehensive update. And transition is never easy and stuff, and I know it's been incredibly difficult and prolonged. So I just wanted to once again take an opportunity to thank you, Mike, and other colleagues for retaining the focus on the here and now and what's to come. And again, and everything we do is for the interest of our communities and patients that we're here to serve. Any other questions or comments from anybody? No, that's a really comprehensive update, and we've got it, the report too. So good. Thank you for that, Mike. Over to you then, John, for our Chief Clinical Officer report.
So thank you very much, Chair. Thank you, Majid. We are going to spend a few minutes thinking mainly on some more clinical parts of our discussion this afternoon in this public discussion. I do want to go on record, to add my thanks that you've already raised. I'm aware that if any of us get jobs onwards or upwards, it's because of the work that all of us have done. And I think in Oldham we have absolutely tackled the real issues, and we've done it in the right way. And I'm very conscious, and I won't spend too much time on this, but I'm very conscious that none of us are as clever as all of us. And one of our successes in Oldham is that we have found a way for all of us to have a voice. And with the current health authority, we've heard and we will hear about how this health authority will transition during the white paper. And although it has been a somewhat disruptive process, in my opinion, I hope that we manage to remember what makes us good and best, and that we carry on trying to give everyone a voice and making the idea the important thing, and not I want to say a little bit about COVID, a little bit about mental health, a little bit about system performance, and then just finish with something else. So COVID is still with us. This morning, Mike, Claire and I went to a meeting, and one of the reports in the meeting said that SAGE's assessment is that over the next 5 years, COVID will not reduce to background flu. It'll still be more than endemic over the next 5 years, and there will be occasions in the next 5 years when there is a threat to our public services being overwhelmed. And that's quite sobering, because that paper also included the standing down of widespread testing. So we have yet to see the final details, but this month marks the end of widespread free testing. And it's an interesting time, because when I attend the meetings, and I don't think anything I share in this public meeting is embargoed, we still have a rise in cases in all ages, in all sectors of society. We are on the second variation of Omicron, BA2. BA2 is rising quicker than BA1 is shrinking. And it is impacting I have no doubt that anybody that watches this, or anybody who's on this meeting, knows somebody who has been reinfected or who has had an infection. And we're seeing those issues. The interesting thing is that, of course, in Oldham and Manchester, we tend to get the wave last, but the wave is definitely here. So 2 weeks ago, 6% of people in hospital had COVID. As we speak, it's 11.3% of people. And we can answer some questions that have been posed in social media and through the public, which is, half the people in hospital, Majid, are there due to COVID, because of COVID, and then the other half are there with COVID. So it's about 50-50. And I mean, that's clear, because normally when it's just COVID, we see the cases in hospital bounce up a week after the cases in community, but now we're seeing they're more or less in step with each other. And our positivity rate is actually climbing, but in Oldham we are still managing to test our population, and our positivity rate is beneath national averages, and has been for the last couple of months. So although people are getting tested less, I do think our numbers are real. I'll come back to that at the very end. One of the things that concerns me is that I suppose even myself, as other variations, but what we've now discovered is that the blunting of the Omicron effect, so numbers go up, hospital numbers go up, but ITU, HDU numbers don't go up. What we find is that's due to the vaccination program. So I want to thank everybody here. I want to thank our GP and nursing workforce, our hospital workforce, who have ruled out the vaccinations. And to say very publicly, it is the vaccination program that has saved our numbers being translated into more misery. And as humans, we unfortunately are such a diverse and variant group that we always have a controlled experiment somewhere in the world. And you know, I hesitate to even speak of it, and certainly not in a light way, but in Hong Kong, where they're now experiencing Omicron, they are telling us how severe it is, because they managed to vaccinate their young adults, but not their most vulnerable. And the mortality in Hong Kong is there for people to see. It is severe. So if we were not vaccinated, if we were not wearing masks and doing the things that we've asked our public to join us in, we would be in a similar situation as Hong Kong. And so as of this week, we are rolling out the 4th round of vaccinations to the most vulnerable, to people in care. I encourage everybody who listens to this, all of us to continue with the central message that vaccination is key, especially if you're vulnerable. So absolutely want to make that point. And we do have plans about how we'll stand back up testing if we need to, how we can stand things back up. So that's the situation with COVID. I saw a figure, Chair, last week, and we presented it to the GPs, that we can track sick notes that are issued and why they're issued. And you won't be surprised to know that sick notes for mental health have started at a medium level 2 years ago when we first locked down. And they're the one number that has consistently grown month on month to now. We have issued this month the most sick notes for mental health than we have ever done in Oldham. And that, of course, tells us what's really happening to our population. Again, we know colleagues and family members who are struggling. So again, I would encourage us to remember all those measures we've put in place to support colleagues and to support the public, the phone numbers, the websites. And you know, anyone that hears us today, please do speak to somebody if you're struggling with your mental health. Everybody wants to take a deep sigh of relief. The summer's coming, you know, restrictions are lifting. It's time for serious people to keep on being serious about these issues. Which then leads me to our non-COVID clinical performance. And it's been another difficult week in terms of the messages. So we are stepping up our elective recovery, which means we are going to our waiting lists to get people's stones out and to get their knees repaired and to get their diabetes under control with tertiary specialists. And people will be aware from the news that we used to talk about an 18-week waiting list, but now we're talking about a 104-week waiting list. So the new health authority comes into play in July this year. We hope by then we will have nobody in the Northwest on waiting longer than 2 years. We hope that by next year we get to 78 weeks, and at some point next year we get back to 52 weeks, and then we will start to work towards the 18 weeks again. There has been some resource from the government. It is being well spent. And there is a team in Manchester, Greater Manchester, a team in Oldham who are working very hard for our public. We are very aware of the knock-on consequences. There was a recent paper, Chair, that showed that opioid prescribing has gone up by 5%, purely based on lockdown and people in pain waiting for their operations. And that is a challenge that we are already having plans to address. Unfortunately, deaths from opioid addiction and overdoses hasn't doubled in the last 5 to 10 years. So these are the serious problems that we have to deal with. We also have a problem with ambulances. So we don't directly commission our ambulance service, but the chief operating officer of the entire NHS for England has been doing a roadshow, and he came to Manchester this week to say it is the worst crisis of waiting times for ambulances that he can remember in his long career. Some parts of the southeast of the country, you will wait a very, very long time to be seen, even if you're category 1. And when your ambulance gets to the hospital, there are cases of people waiting 17 hours in that ambulance before they get into hospital. Here in the Northwest, we have been working in our collaborative integrated way for quite a while. Our average wait at the hospital, or our worst wait at the hospital, is only an hour as opposed to 17 hours, but that is a very fluid situation and we continue to work hard. Also, we are managing to see people in category 1 in a timely way that's almost near the national standards, and also for category 2, but that is a lot of work that we are trying to do. So all these myriad of problems all happening at the same time in the hospital. And then of course we have general practice, where we should expect, if the hospital goes from 18 weeks to 2 years, what will happen to general practice? If the prescribing demands have increased, what will happen to general practice? So I want to commend to the board my colleagues in PCN leadership, my colleagues on general practice front door, and it's not just GPs, it's GP nurses, it's GP receptionists, it's all of primary care, which is more than just general practice. But we are rightly proud that we have a service run mainly by Oldham people for Oldham people, but even those who aren't true-born Oldhamers like myself and Dr. Vance, the service is full of people who care, and I want to mark our thanks yet again specifically that they turn up and that they don't shy away from these difficult problems. So there's more I could say, but I think this meeting needs to move on. I do, however, have one last thing to bring to our attention. This is our last formal full board, and we have already said thank you to our colleagues. It's interesting, if anyone leaves this meeting and goes to The Guardian, they'll see that in The Guardian they are tracking case numbers across this country. And we said at the very start, you'll remember that unfortunately the government said at the very start, if we lose less than 20,000 people, we will have had a good pandemic. And we all know that we have unfortunately and tragically lost 163,000 people and counting. But there's another 20, Majid, that we said here as a leadership team that if we could stay outside the top 20 for cases and deaths in the pandemic, we would have achieved something important for our population. And you've heard me before, the statistics of humans with the numbers wiped off. So I don't talk lightly of numbers because I know the people who we have lost. However, we set ourselves a target that we would, 2 years after the first lockdown, that we would try and be outside the top 20. The reason why we chose that number was because we are in the top 5 for deprivation, and we know that deprivation and COVID really mix. So if you go to The Guardian today, you will see that our all-time case number in Oldham puts us 108th in the country, which puts us just a few places above Oxford. It is remarkable to me that our door-to-door work, our community work, champions like yourself, Majid, the lay members getting involved, Claire and her nursing team, the money that Kate got us, the leadership that Mike showed and others, the work that the GPs did, is meant that our case numbers which are verified by our positivity numbers, show that our case numbers in Oldham have been the same as Oxford. And a pause there, because no one will come with MBEs. No one will, and we don't want to put up bunting because too many people have died and too many people have suffered and got long COVID. But I don't want this organisation ending without us noting that community commissioning, community leadership has a solid effect. And if you want to hear the twist of the knife for deprivation, so Oxford, which is remarkable, and we must not forget that that was achieved by all of us. But when it comes to deaths, Oxford are 200th for deaths, and Oldham is 42nd, and that is, more than we've achieved what we tried to put out. But isn't it interesting that the same amount of cases, when you put it through deprivation and societal inequality, leads to such a difference in deaths and loss? So I still stay angry, Chair. I still think there's much work to do from top to bottom. Remember that we have achieved. Thank you.
Yeah, thank you very much, John. Some of them words didn't come through. I think there's an issue with the mic or something. But every right to be angry about some of those statistics, and COVID has just added to the huge challenges we were already facing. And this morning I was with members of the community, and they were talking about the impact on mental health, particularly. And the amount of work that we need to do to help people get better and be the best they can be. COVID, I'm glad you sort of brought that back to the surface, is that it's almost a forgotten topic out there, but it's still dangerous, it's still out there and stuff. And Oldham has been remarkable in addressing and some of the challenges COVID has brought, as you just mentioned, particularly preventing deaths. Had we not done what we have done collectively, we would have seen a very, very different picture. And again, that's credit to all of our colleagues and collective work and partnership working. Mike.
So thank you, John, for the sobering reminder of the impact of COVID. I just want to add a little bit more to that, really, just as we start to look ahead. So of course, some people will be impacted by the new proposed changes by the government, but the majority of people who work in the CCG will not be. As I reflected on it, I just happened to be in London yesterday, and it was 2 years to the day, literally 2 years to the day, that the pandemic started. And there are people in our team who'd been in the CCG for 9 months, 6 months, let's say. And when we look at the work that they've delivered over the past 2 years during the pandemic, I can't help but imagine what we would have achieved if we'd have had a full 2 years together, not dealing with the pandemic. And it's actually really, really important over this period of time that we spend the next 3 months making sure we document some of the things that we've achieved, that we celebrate some of those things, and those people that do go forward onto the next stage of this journey, take some of that with them. I am mightily proud of the work that this organisation has done, the people in the organisation that have done it, and it's never been about the organisation. It's always been about the town. It's always been about the people. It's always been about the place. We've had some disagreements. We've had some sweet moments as well at the same time, but we always kind of come out with some really, really great results, and it's been a pleasure to see it. I can't help but think that some people in our team who joined us towards the later stages, as we were just getting going on transformation, will feel a sense of loss that the organisation will come to an end, but hopefully a sense of relief that their capability will be carried forward into a new world for the benefit of local people. And that's not just about the employees, it's about GPs that work with us, it's about the nurses, the doctors, everyone. I certainly remember some of the really challenging conversations that we had right at the start of the pandemic that were full of all of that stuff, John and I sticking our necks out about getting testing up and running before anybody else in the country really knew what they were doing, sourcing different ways of doing things early. So we got in front of it as quickly as we can. And it's because of all of that work that people have done that we start to see ourselves being compared with probably one of the most desirable parts of the country or towns in the country to live in, to be frank. And it's brilliant. And it goes to people like yourself, Maggie, from knocking on doors, getting the community to do things for themselves. So we've a lot to be proud of, and we've a lot to look forward to as well at the same time. So thank you.
Thanks for that, Mike. And of course, huge amount we've learned on the journey too, which I know, Mike, you and other colleagues will take that forward into the new world. Good. Any final questions, comments from anybody, observations before we move on and talk about the money? No? Okay. Kate, over to you then.
Thank you, Kate Rigdon, Chief Finance Officer. So this is the finance report to month 11. We're forecasting a break-even position after the anticipated reimbursement for the hospital discharge programme. That's the National Hospital Discharge Programme, of 1.3 million. After winter access funds of 0.7 million, and for some hosted funds that we do on behalf of GM for the vaccine service. And that's 0.1 million, and that's for Q4 anticipated reimbursements, and that's a total of 2.1 million. So after we receive those funds, we will be at a break-even position. Savings are on target to be achieved at the end of H2, and that will be 3.7 million. So the emerging challenges that we've seen through H2, specifically regarding high cost cases as part of continuing healthcare, we've actually managed to mitigate those through underspends that we've seen around the independent sector. They haven't had activity levels to those that we planned, and that has mitigated those costs for us on a non-recurrent basis. So I think it's key to say that we're still in the COVID finance regime, and as a result of that, we have seen a greater level of funding, and as we move back to a pre-COVID allocation level, we will see an emerging underlying pressure start to emerge over the next few years through the planning process. And I think it's important to note through this report that although we're reporting a break-even position forecast outturn for the end of this year, future years will be significantly challenging as we move back to those sort of historic allocation levels. And so there's going to be a significant amount of work that we need to do as an organisation and as a system to reduce those costs going forward. So I'm happy to take questions. Okay,
thank you very much for that update. Kate, any questions, comments, anybody? Derek.
Question, just a comment and a note. I think it's important that we note that despite the disruptions and upheavals of both COVID and the preparations for moving into the new regime in the forthcoming year, that the CCG managed to break even and, more importantly, managed to make savings of £10.4 million throughout the year. I think that's a really creditable performance and something that we should be happy to note.
Yeah, absolutely happy to know, and really thank Kate and the team for the brilliant stewardship of our finances. Every pound matters, and it's really important that it's spent wisely and gives us the best outcome for the people of Oldham. And the team have done a sterling job on that, and colleagues who've made the savings happen in practice also. Any other questions or comments? No? Okay, let's move on then to Claire, the quality and safety update.
Thank you. So Claire Smith, Director of Nursing and Quality. So the report covers some of the key system risks in the period since the last board meeting, and just wanted to draw people's attention to a couple of the points, but taking the main report as read. Point 2.1 with regards to waiting lists, as John referenced, this is one of the biggest areas of focus in the kind of the say post-pandemic recovery, but as we've just discussed, I'm not sure that that's an accurate term at this moment in time, but really recognising that national directive to eliminate waits of longer than a year by March 25. So just to give a little bit more detail from some of John's comments, there is a renewed focus and members of both my team and Nicola's team are sitting on the groups at the NCA to ensure that a really robust approach is being taken to this. The plans are in place, and particularly with a focus to eliminate 104-week waits by the end of June this year, and really pleased that the Trust are on trajectory to achieve this, which is great, and we are working in that kind of holistic way, looking at the harms associated, the performance, etc., to really drive this forward. I guess one of the things that is noted in the report is around maternity services, and just to say, as per the action log, we plan to bring an in-depth maternity review to the June meeting. So not going to go into much more detail here, but just as a recognition that we have discussed maternity services on numerous occasions, and if there is anything that governing body would like to see specifically reflected in that deep dive, then please do let me know, and we will ensure that those things are covered. Going down to 2.2, we've talked a lot today already about how Oldham people and communities are absolutely at the heart of our model, and I just wanted to draw attention to what's quite a brief flag there in regards to the system quality assurance and improvement model. And I'm really pleased to be able to come to the governing body with the acknowledgement that this is now a working model. The group has met on a system-wide basis on 2 occasions. It commenced in February with a really positive enthusiasm and momentum going forward. That model will be finalised through the IDB and system board governance structures in the next month or so. But I think what's really important about that is recognising that all of the work around transition and close down, everything that we are focusing on in this time of change, the people of Oldham and the locality remain central to this, and this is part of our absolute safety net to a certain degree, to make sure that the needs of Oldham people, the needs of the locality, are reflected both in the sort of the day-to-day work that's being done, but how that is reflected back into the Greater Manchester system. So it gives some assurances there that the needs of Oldham people will remain central despite all the change that is going on around us. And then finally, to finish on a positive note, the next point in that section is around the flu programme, and as we come to the end of the designated flu season, the charts there just show the progress that was made this year in terms of flu vaccinations, and linking back to again John's earlier comments with regards to COVID vaccination. This again is a tool in our arsenal to keep people well, to keep people functioning and protected. It's not always easy, and I think some of the learning from the COVID programme has really supported our approach to flu and our reach to certain parts of the community. Yes, there are certain areas that still there is more work to do. Maternity, pregnant women and learning disability services are 2 areas that we can do more work on to reach those parts of the population. But just looking at the 3-line graph at the bottom there, you can see that the red line is the 21-22 season, significantly higher than 19-20 and 2021. Given the push that we had in that year. So I think just a real commendation for everybody who was involved, our primary care leadership, the connectivity through the hospital services, our community nurses, our care homes. It's been a real collective push, and the results there are absolutely, speak for themselves. So to end on that note, a really positive way forward, and again lots of learning that we can take into the next season that will help us hopefully to push those targets even further. That's as much as I wanted to pull out of the report, but happy to take any questions.
Okay, thank you very much for that, Claire. I've got a couple of questions for you, and I know Mike wants to come in. So in terms of maternity services, really pleased that 7 of the 9 actions have been complete and 2 are imminent. In terms of the final report, I recognise in there will be what's been done to correct the sort of challenges that were identified, but it'd be really good to see what's being done to prevent those sort of issues from occurring again, and so also sustaining the improvements, recognizing the huge challenges with workforce and everything else that we've been discussing. So it'd be good to see that in the report when the report comes in. And second thing was around children's mental health, and it talks about a toolkit that was introduced, and we're really pleased that is working. Be good to keep an eye on this also. I think about children and mental health, and again this morning's meeting what I attended with members of the public, much concern about young people's mental health, etc. So just want to keep on the radar, which I know it is, but so then were my 2 comments. Mike.
So it's just we're sort of straight into the next paper with my comments a little bit, really. There's probably more for Nicola than it is for Claire, but Claire presented a paper that almost sort of gave us the impression that sort of waiting times were easy to resolve. And I know she never meant that purposely. It was a small part of the whole paper, and it's important actually that we recognise that that's absolutely not the case. So, Nicola, I know Claire mentioned that the NCA were on track to deliver against the 104-week wait. What's your assessment of where they're going to end up and where we're going to end up in Oldham in the end?
So it's a tricky one, and I think Claire and John have both taken parts that I would talk about in the performance report. When we look at 104-week breaches, the Trust, and I had confirmation from their operations director this morning that they're absolutely, and Claire's right, they're on trajectory to have that delivered by June. This is the complicated part, is that where they are looking, and part of my report will talk to you around how the reduction in waiting list is being improved quite significantly. The challenges are incomplete waits, and actually there's a balance here, because the incomplete waiters are the real challenge. That's where Claire and I will start to do work over the coming months, because just as we've found that we can start to improve waiting lists and do clinical triage and referral and get those priority patients on a trolley for their surgery and for their the delivery of care, it's actually incomplete waiters that actually is our next area of concern. So there is further deterioration around that. There's further deterioration around diagnostics. All of that then will have an impact on people waiting, and so therefore we will then start the whole journey again around people on waiting lists. So it's complicated at the moment, but we are seeing some green shoots, and I think that reflects where Claire's saying the one good thing is we're absolutely one of the only trusts that are on trajectory to deliver 104-week 0 waits by June.
So we all need to hear that, don't we? We're doing as best as we can, but there's a risk that there may well still be people waiting over 2 years at the end of June, but that will not be for the want of trying on our part. There's a recognition that there's a much more complicated picture. So thank you for that. I think it's important that we're quite clear about it publicly.
Thanks, Mike, and thanks, Claire. Any other questions or comments for Claire? No? Okay, we move on then to Nicola and the corporate performance report.
Okay, thanks. So just to say, both John and Claire have touched on the performance. So just picking up around the elective care performance, and then I'll move back to the other key areas. there's 33 people left, Mike, in response to your 104-week raters that are left to be given a date. Everybody else has either been treated, has a date to be treated, or are currently being. What that means is there's 5 lists for people that, you know, don't perhaps understand theatre utilisation. That's 5 lists of people, 5 theatres that need to be booked and delivered in order to finish off. And that we are looking at. So it's very, you know, as much as we hear that the public are wanting to have their treatment, that are ready to come and have their treatment, that are in pain, that are feeling unwell, more unwell, we are seeing some of the highest non-attendances, DNAs, we've ever seen. As an organisation, as a borough, as a GM, nationally, because we've had people that are currently ready, prepped, on a trolley, ready to go to theatre, and for lots of reasons, often personal, have decided that they don't want to continue with that treatment. That person then has to go back on a waiting list, but that's also a missed opportunity for somebody else. So we're doing a lot of work with the trust and a lot of work with patients to look at the reasons why that is. And some of that is COVID, some of that is fear, some of that is because they've actually on clinical triage, things have deteriorated or improved, and we need to hear that as well, that people are improving because of other treatment that's been delivered elsewhere in the system. So the whole work around the elective care schedule is complicated because it's bubbles, isn't it? And we see that very much when we start to look at cancer performance. We deliver 62, we don't deliver 31, and every time we look at our cancer performance, it bubbles up in different areas, and we do a priority focus, and we are limited to the clinical workforce, we're limited to the clinical space, we're limited to the clinical theatre availability, and we've got more demand for this than we've ever had, ever. The challenges that we have around that is, of course, we're still working under COVID restrictions, obviously, and you've heard the reasons in John and Claire's report around this. That means that our availability for space for treatment is reduced still because of infection control and prevention. And so that whilst we've got a need to step up around elective recovery programme, we've also got higher numbers than we've ever had of people being more acutely unwell for general reasons, whether that be through COVID, whether that be because they've not had elective surgery and so deteriorating long-term conditions. You know, the 2 years of lockdown that Mike talked about, it's impacted significantly on people's health. We know that. And so we've still not, you know, we don't have any different space. We're still locked in the same estate that's been reduced by circa 100 beds because of infection control. And so, you know, there are some real positives. So, you know, I talk about the waiting list this month. So the report that you get is 2 months behind. The new data that's been run this week, we're looking that there's approximately a reduction of 584 people on 6-week breaches that's been reduced by. That's a significant number, and that's just for at the Northern Care Alliance. And when we start to look at the breach rates dropping circa 10% around waiting lists in general, that's impressive. Now you won't see that until the next governing body report, but the work is happening. The problem is we'll see that bubble up somewhere else, and so our work begins. So Claire referenced the work that we're doing around the waiting well, and we're doing that from a Greater Manchester position. We're doing that as a very focused piece around Oldham, and Mike, John, as well as others, are involved at that as a strategic perspective, and we're operationalising all of that. And it is starting to have some effect now, and I think the communications that we're doing working with patients and GPs is working well. In other areas, John talked about the mental health impacts. Again, I think that Mike referenced in his accountable officers report the work that we've done as a team and has been kind of slowed because of the 2 years lockdown and COVID and the pandemic. Actually, where we are is we're now starting, and we've got for the first time in many years, a joined up operational plan to work with the I'm not trying not to use the acronym, Pennine Care Foundation Trust, which is our mental health provider. And actually we've started to work with them around financial flows, working with Greater Manchester and the partnership, and looking at how we can start to utilise with the local authority delivering mental health services in a different way. And we're certainly seeing improvements when Claire talks about the improvements around complex care and the reduction, and Kate referenced that in the finance report. I hope you've seen that actually we're starting to see that it's impacting everywhere and we're not just working in silos. So there are some positives. I know that they're slow, and I know that you always push us for more, and that's absolutely right, but we're going at a pace that I think is a sustainable pace, and we're starting to see some improvements there. Still not perfect by any stretch, but we are working with the trust to make sure that we deliver where we do. Ongoing challenges around our urgent and emergency care network, whether that be through A&E performance, and you know, we are nothing but consistent around the 55% mark of a 95% target. I know that sounds dreadful. I know how that sounds when there is a 95% target to be achieved for people to be seen within 4 hours. Having a consistent delivery is a positive thing. If we were seeing 95, 50, 40, you know, up and down, actually we'd be more concerned. What this is telling us is that we know that there's challenges. This is definitely not, our performance is not based on our throughput and our discharges. From a GM perspective, we are one of the best, and we are one of the best nationally in Oldham for our discharge services and patients' length of stay. What this is demand, and it is capacity of estate. But we're working with the national team. Mike and I have met with them on several occasions, and we've worked with them about actually what it looks like to start to develop our estate, and looking at how we work with our primary care networks to develop broader services around same-day emergency access and all of that. Work with NWAS is challenging. We've had some great improvements over the last 12 months, and then we've seen some stark deterioration in our performance around NWAS, but John referenced we don't and are not the commissioner. So we're working with Blackpool, who is the commissioner, to look at, and with GM to look at how we can work and more improved recovery plan, because it is needed to be owned by all partners in the system, not just one front door has to be owned by the ambulance service as much as every other trust. And I'm positive that we will get back to the recovery and the response times that we saw in early summer last year. And then one thing that is it's unusual, we've not had any mixed sex breaches since January 20, and that was due to a challenging winter. We've had 35 in January, and this is purely down to an increase around COVID. The trust are aware, they are very much on a path of that hasn't happened since. It was a decision that they took with patients as much as it wasn't just on their own. I know Claire's team are involved, my team are involved. And again, it's a challenge, but, you know, patients were safe in a bed. It just happened to be a mixed sex, but the patients were triaged effectively to make sure that they were safely there as much as we could have. And then finally, the trust has submitted all of the recovery plans, and we are very much actively involved with them, and that's something that I do regularly with my team, and work with Leah and the team over at the trust to make sure that it is very much a system delivered recovery plan from an acute perspective. And that's the key highlights, if anybody's got any questions. Thanks.
Thanks for that, Nicola. A mix of huge challenges and a mix of green shoots and recovery and challenges with the estates, etc. One of the things that when you mention about DNEs, people who are not attending for whatever reason, and there'll be 101 reasons, I'm wondering if it's worth contacting Action Together. I don't know, Timur's listening on the call, is whether we can do something through the community champions networks, etc., to get the message out that, look, this is what's happening, why is it happening, do people need support, etc.
We're not at that point yet, Majid, because these are clinical reasons for DNAs and clinical reasons through. So this is people being on a trolley, then stepping back. So this, as it stands at the minute, it's not people just not turning up, which is what we ordinarily would see throughout the year. People generally just don't turn up to an outpatient. People generally don't turn up to a GP appointment. This is much more deep rooted. So absolutely, it's on our plan to work with Action Together, Health Watch, work with community interest groups to understand. But as it stands at the minute, there isn't a pattern. And so this is very much something that we need to do as a clinical system with the team in the acute, the team within primary care, to then start to understand how we then action it. I think it would be detrimental to the programme that we've got at the minute to start to include others because we haven't got that clinical understanding yet. And that's not dismissive, that's just the facts of where we are.
Okay, no, it's me. I misunderstood slightly, but if we do need to, then there is a resource there that we could and should tap into, and I know you will do that. Any other, Mike? Mike, I think you're on mute. Yeah.
Trying to get off mute though. Sticky buttons happens occasionally. So it's just a quick thing, really. I don't think we should be too hard on ourselves around the 4-hour A&E target. I know there's a public meeting, but actually there's a lot of controversy and debate around that target right now. The main thing is that people are going through A&E and they're being managed in an appropriate way from an infection control point of view, given that COVID's still kind of in quite wide circulation. And actually we kind of closed down quite a lot of things as part of the pandemic and as we go back. The issue remains, though, that the A&E department is kind of generally built to accommodate about 250 people per day, and pre-COVID we were at 400, and with the site redevelopment programme in play. How realistic do you think it is, Nicola, that we'll get to a place of having a target that's actually deliverable and manageable? And that's a rhetorical question. Maybe the policy makers nationally need to answer that. But we'll end up with a site that's kind of got the type of infrastructure that we will need going forward, probably alongside the wider stuff that we need to do through PCNs around differential approaches in different networks.
It's complicated. Do I think that the policy will be changed? To do? I think it will need to be because of how clinical care in an emergency department is being delivered. And so 4 hours was based on all accidents and emergencies going through. We're now having opportunities for same day emergency care to be delivered in other areas. So I think it will, but it will take time given all the other changes, or at least I hope. From an estate perspective, it's long term, because although we have other offers available across the community, it's work that we need to do with our population, both in Oldham and outside of Oldham, and also with the systems that feed our emergency department. 45% of our activity comes from borders. On average, there are days when it's more. So, if we included wider GM, it's over 50% of our activity comes from outside of Oldham. And so when we start to look at people just know our front door, we can communicate with Oldham and to look at getting them to other estates. And so it's going to take longer than 12 months. Do I think we'll have a better estate plan? Yes, we do. It's in hand, but that takes time as well. So at the moment, it's about how do we utilise what we have and make sure that we stand by our NHS constitution, which is the closest, most appropriate place to receive your care, and work with our population to understand that, because there is still a lot of our population that wants assurances from that front door. And I understand why. And so we need to work with our population to understand what will change your mind on that. you know, how do we improve access? Improving access in primary care has happened. It is starting to improve, but yet that hasn't had an impact on the front door when we thought it would. So there's lots for us to do. That's something that's happening across GM as we start to close down the CCG and work across the GM network. That's something that will be supported by the partnership and the ICS as much as it will be just from a locality. But again, it's the need for us to keep a locality flavour because we understand our population. It's probably not the answer, Mike, but it's a reality.
Good. Okay. And any other questions or comments for Nicola? No. Okay. Let's move on then to the board assurance framework, and over to you, Erin.
Thank you, Chair. Just in case anyone's observing the meeting who didn't see me introduce myself right at the beginning, Erin Portsmouth, Director of Corporate Affairs for the CCG. Okay, so this paper on the board assurance framework, I wasn't planning to go through the framework in detail. We make a commitment to bring obviously the board assurance framework to governing body and certainly publish it through our public papers on our website. We do talk about this in quite a lot of detail in our audit committee meetings, along with the wider risk management framework and our wider operational and corporate risk registers as well. The main reason for bringing it today was because from a technical point of view, we would like to close the board assurance framework down for this current financial year and effectively are proposing to reopen it for the quarter of the new financial year that we will be operating as the CCG. As some background for those who aren't aware of board assurance frameworks, this is the set of high-level risks that we see to the risks to not delivering against our strategic objectives. And the framework and the risks within were developed through engagement with our governing body members, certainly talking to them about what keeps them awake at night, what are those things that are playing on your mind in terms of those high-level risks, which has led to the development of the framework itself. It isn't a static document. We track, we monitor, we make sure we're recording any mitigations that we have, but also that we've got action plans for where we have any gaps as well. The other thing I wanted to mention is we've just had the completion of phase 2 internal audit of the board assurance framework and our wider risk management processes as well. They noted that the board assurance framework was visible. It is used by the organisation. Based on looking at some of our other meeting documentation, they can see that the risks that we discuss in our formal meetings translate and impact on the board assurance framework and our wider risk management as well. And we did get a substantial assurance report and with no recommendations, which is quite unusual for any of my colleagues who deal with internal audit reports on a regular basis as well. Normally we'd bring the corporate risk register, but we're actually, the way the time of the meeting has worked, we're actually in mid-cycle at the moment of just updating those. So we will bring the corporate risk register to the next governing body meeting as well, so you can have a look at those high-level operational risks. But again, we also talk about them in a fair amount of detail within our audit committee. We have also just undertaken a deep dive of some of our risks as well with our audit committee members. And yeah, so happy to take any questions. I suppose the main kind of approvals I'm looking for is if the board is happy to close the board assurance framework and reopen it for the next quarter.
Thank you very much for that, Erin. We've got Derek and John with their answer.
Yeah, at the audit committee for a number of years, we've sought to get an improved and more dynamic board assurance framework and risk control and mitigation. We've now got it, and I think we're seeing the benefits of that in that if you look at the direction of travel of the risk scores, they're either in the main they're on the way down, and that proves that if you've got a quality format and a quality procedure and a quality recording, you can better mitigate your risks and understand your risks. And I think that's down to the hard work of the people behind it, Erin and Virgin and others in their department.
Thanks for that, Derek, and acknowledging the huge progress we've made with this framework. And these are some of the things that are at risk of sometimes just being lip service, but I think we've really brought this to life, and it's been reflected in the audit and the constant movement in managing those risks, as you've rightly pointed out, John.
Thanks, Majid. Just to echo a bit of Derek's point, and then to sort of develop it, so it feels like it's taken 9 years to get us in the right place with discussions about risk, and to get them in all of our front heads and front brains here as the governing body. So I think the risk now is that as we transition into a system board, when is it appropriate to start bringing this discussion into that area? So I think we do need to, especially when we think about quality and safety, and we've got these two big providers who are across localities, what the people of Oldham need is a sensible, localised conversation about risk. So I think we've done really well. It's clearly turned around since you turned up, Erin, and Brigine's, all credit to her and her passion for risk. Nevertheless, we now need to think how we transition this work. Thank you.
Yeah, if I could come back on that, because I think that's a really important point for us, because we also know that organisationally, not so much within the NHS, most of the NHS and so our provider partners will adopt the same sort of level of risk matrix that we do, for example, in terms of scoring, but we know that the council scores their risks differently. So there is something, even just from a process point of view, about how we bring that together for consistency. I think as well, as we're talking through the governance and development of the system board as a formal locality board and subgroup of the new integrated care board at GM level, we will have to make sure we are being mindful of risks based on delegations that we have, based on any stewardship of money that we have. So I'm hopeful that what we can do is build on what we've already done, not lose any of that, and start to transition that over into into kind of the new system governance as well, because because we're players in that, aren't we, and we're spending time in terms of actually doing that development. I think there's something to say, actually, we've got a model here that works, and we can talk through with our system partners about if they're supportive of kind of working through and adopting that model. And what we need to do is just almost do some reset work, I think, and engagement conversations to see, actually, do we need to kind of develop change, certainly at a kind of high level versus the operational risks. So I think we certainly don't want to lose the work that we've done and want to carry it forward.
Thanks for that, Erin. Any other questions or comments? Are we happy to approve the recommendations as made by Erin? Yeah? Okay, good. Okay, let's move on then to staying with you, Erin, on the modern slavery statement.
Yes, so this, hopefully it's an information item, so hopefully it shouldn't take too long. For those who aren't aware, the Modern Slavery Act legislates for commercial organisations to make sure they have action plans in place to obviously combat modern slavery within their own work domestically, but also their supply chains. So while this hasn't happened yet, what they're looking at is extending the Modern Slavery Act to cover public sector organisations as well. Now, we already make statements that we support the ethos of the Modern Slavery Act, but obviously we're not actually yet having to make a formal statement around our action plans on it. I think if as a CCG we were continuing to exist in our current form, we would certainly be looking at building that up now, but this will be something that the new GM Integrated Care Board and organisation will need to take into account as the legislation and the regulations expand. What we have done, though, is we have reproduced what is a very simple paragraph around supporting the ethos of the regulations, and that we have published that on our website, and we have registered that with the registry that's being held nationally, and we also report this into our annual report as well. So it's more for information for governing body. It's, like I say, I think it would be something as a locality we would be looking at as from a process point of view if we were still here as a CCG, but it's something I think it's something we still need to build into the new world when we talk about things like developing workforce, work with employers. We will need to keep leadership roles, won't we, with our local economy around some of this. So it'll be also how we work with our partners and local businesses and encouraging everyone on this side of things. So happy to take questions. It was more of an information point.
Okay, thank you, Erin. Any questions or comments? No, really pleased that we've brought some of it to life, or with the paragraph that you've mentioned, and again, have a commitment to make sure that it is centre stage in the new world also, because it would be really important that we are on top of these things. Okay, still with you then, Erin, on emergency preparedness.
Thank you. So back in September, and when we also met in public as a governing body, we did report our core standards as a CCG in relation to emergency planning, resilience and response. That's something that we have to do statutorily every year. We reported those in September and had those approved by the governing body. As it was noted in the action log, we were still, we needed a longer period of time, which is the same across the board for all of our colleagues in other CCGs as well, to report the standards of our main commission providers as well. So this paper outlines that. We did talk that through in one of our interim governing body meetings in a fair amount of detail, but it's important, I think, for this report and this paper to be provided to this governing body and also published on our website, so obviously members of the public can see around the core standards. The main summary from when we talked about this previously is that there are no concerns around any of that. There is enough assurance there around our two key providers, Northern Care Alliance, which is formerly Pennine Acute, and Pennine Care Foundation Trust, around their emergency planning, resilience and response. And we all work as an EPRR community. We have meetings as both a North East sector group and a Greater Manchester group, and that is not just commissioners, that is a commissioner and provider group, so there is a lot of cross working. But yeah, so this is brought to the governing body for information, and so we can also publish that for on our website so people can take a look at it.
Okay, sounds straightforward and sensible. Any questions or comments? Anyone? No? Okay, we'll give you a little break then, Erin, and hand ourselves over to John to talk to us about.
So, Chair, this is the bit of the meeting that everyone looks forward to. You have 258 pages of documents, and I have supplied 200 of them. We'll take about 5 minutes per page. We should be okay. Whenever this governing body finishes, I will be available on Fridays and Thursdays if you want to phone up, and I can tell you about the paperwork. So unfortunately, I don't think my mic is great, Majid. I love this office. I genuinely love my office in the council, but I'm in a bit of a Faraday cage when it comes to Wi-Fi communication. So I will keep it brief. You'll all remember by now how these pieces of paper get to us. Last time we said that because clinical committee's been suspended, you've been at the mercies of a couple of us leaders being part of that process. Now that we've stood up Clinical Senate, Clinical and Paraprofessional Senate, these papers will start to be read by them, but by the time we see it, they've already been through a specialist EOR group, a specialist effective use of resource group, and they've already been socialised through a GM, effective use of resource. So it's really up to us as a localised Senate to make sure that we understand it and the system can respond to it. So if we suddenly say we're not going to do any more knee operations, it's our job to make sure the GPs know that. If something like that was declared, we'd obviously have an uprising and we would, go back up through the system. So what we have before us are a couple of policies. What's unusual or different this time is that very often these policies are just the GMification. So they're describing how all 10 CCGs are starting to adopt the same policy, and if there is any individual variation. So that's definitely sure about the spinal stuff. There has been a change from last time in that you can now get one spinal injection a year if you qualify they were completely taken off. Now they're back on again, but the criteria are very strict. The low back pain is just a collation, so that's why it's GM version 2.1. The same with the facet joints. And I suppose the one thing that I want to bring to the committee's attention is the assisted conception policy. It's slightly misnomered here in that it isn't Oldham's conception policy as such, it's GM's conception policy that contains Oldham's policy. So it's Oldham's policy as we all passed in 2017. It's not changed, except that we've adopted some of the GM-wide decisions about definitions of a cycle, definitions of what happens if you've decided to have a private cycle of IVF. How does that affect the numbers of goes you have on the NHS? And there's a few more things like that, but nothing at all controversial. As a committee, when we adopted the reduction from 3 to 1, we said we would always review it. I promised to give the committee any heads up if any other locality around the country was going in the other direction. And of course, that hasn't happened. That hasn't happened because of COVID. It hasn't happened because of austerity. It will not happen now because of waiting lists. It's almost impractical to offer somebody 3 cycles now. Before their 43rd birthday, so we remain in the place that we were in 2017, and I, don't want to expand on that. Although if anybody has any questions, I'm happy to answer. So I think that's enough on this item, unless there's any questions. Majid, thank you.
Okay, thank you very much for that, John. Any questions or comments? Anyone? No, I'll be happy to ratify those. Sorry, Graham. You're on mute. Sorry, Graham.
I'd just like to make a comment that for anybody who's listening to this, one of the great advantages of the system that brings these papers to this governing body and to other governing bodies is that it pays attention to what's commonly called postcode lottery, because we're seeing that across the whole of Greater Manchester we're all getting an equal service. Because I'd hate anybody to think that, because you live in Oldham, you're not getting something that somebody in Trafford or Altrincham gets. And this is a really important point of the GM-wide approach, that it does address the issue of postcode prescribing or postcode treatments, and it's to be welcomed, even though, as John said, it's 300 pages of documentation. It is actually very beneficial to the people of Oldham. I think it's important to note that.
Yeah, no. Thanks for that, Graham. Much appreciated. So be happy to ratify those. Yeah, good. Okay, let's move on then to the next item, which is any risks, any new risks we've identified that not being picked up in earlier meetings or not on the register. No. Any other business? No. Oh, sorry, Mike.
Yeah, I kind of wish I was a bit more collected right at the start of the meeting. We've not said a word today at all about the appalling atrocities that are going on in Ukraine right now. And I think we should just take a moment to express our solidarity to those people and everything they're going through right now. It's a complete human tragedy on a scale quite frankly unimaginable to most of us living in the current environment in which we live in. I say that from a point of view of, if we think this won't touch our lives, we're wrong. Every local authority in this country now is looking at what it can do to accommodate refugees in need. And, Nicola, myself and others have certainly been involved in the past couple of days about, services that we might need to put in place. I know John and his colleagues will be looking at GP and medical cover for those people. And, it's a sad world in which we live in, that we're having to face up to these things and, what can only be described as dictatorship and harsh regimes. I'm equally mindful of, the budget that went through yesterday and the kind of growing level of austerity and hardship and difficulties that people in our communities are also going to face. And, I think, everything that we've heard today is quite positive in many ways, challenging in others. Oldham really needs all of us to step up over this next period of time and really kind of be at our best every day of every week as much as we possibly can be, because there are people out there that really, really are going and do need our help and support. So I think we should just take a minute to register some of our concern about the Ukrainian crisis, as well as what will only be described as probably the biggest squeeze in living standards in generations as well. I'm not trying to make a political point, just genuinely. I think it's easy to think that this is something on the news. It's not something on the news, it's something that will be in Oldham and is in Oldham and other parts of the country now. Thank you, Majid.
Thanks for that, Mike. And absolutely, we've already seen people from the Ukraine coming to Oldham and from other parts of the world. And one of the things that I think we can be proud of the people of Oldham, and no matter how much difficulties individuals and communities might be under themselves, when we come across people who are facing difficulty from other parts of the world, we've always done and will continue to do the best we can to accommodate and support and help in any way we can. But thanks for raising those points, Mike. If there's no other business, we've not had any questions from the public at this meeting, and our next meeting is going to be on the 30th of June at 3 o'clock. So on that note, once again, thank you so much to everybody for your contribution. A huge thank you to the colleagues who are leaving the CCG. We really appreciate everything you do and you're going to continue to do in Oldham and beyond. And take care and see you all soon. Thank you. Bye.